Miranda Yaver is an assistant professor of health policy and political science at the University of Pittsburgh School of Public Health. In addition to her academic appointments, she is co-leader of the Central Pennsylvania chapter of the Scholars Strategy Network and is the 2025 author in residence as a healthcare fellow at the Roosevelt Institute. Her research has appeared in a number of leading political science and health policy journals, and she also frequently writes op-eds for newspapers and other public outlets. Her forthcoming book, Coverage Denied: How Health Insurers Drive Inequality in the United States, is coming out in spring 2026 and examines how insurance coverage denials damage patient health and exacerbate a number of social inequalities. Please join me in welcoming Professor Yaver to William & Mary.
Thank you so much. It's been an absolute treat to be able to see Williamsburg and meet some of the faculty and students. Really appreciate the opportunity to present this work today. So this is the rough title of my next book, Denied and Defenseless: The Legal Architecture of Health Insurance Inequity. As you can tell, it's very uplifting. And this is really an outgrowth of my forthcoming book, which I'll talk about to sort of situate what we're discussing. I also want to say, I have undergrads too. I know they don't like to interrupt me always, but if anyone has questions along the way, if I'm saying something that is confusing, or if you have questions, feel free to interrupt along the way. So I don't know about you, but I've talked with a couple of you, and December 4th of last year was a little bit of a strange morning, especially as a scholar of health insurance barriers. Having written a book on how health insurers are harming American patients, waking up to my phone blowing up the morning that Brian Thompson, the CEO of United Healthcare, was killed in New York City was a little surreal. And as I was joking earlier, I know my first thought should have been, this is horrible, this is horrible. In reality, my first thought was, I have to rewrite the preface to my book. But what was really striking about this moment was that, at least to me, striking was that alongside these rightful condemnations of political violence, what we also saw was widespread social media outpouring of frustrations about delays, denials, getting the runaround from private health insurers. Jokes to the effect of, I'm sorry, my thoughts and prayers require prior authorization. For those who have not had the joys of prior authorization, it's in help required pre-approval for prescribed medical care. But what was sort of lost in all of this debate was a discussion about the legal underpinnings of these health insurance barriers. This law that really enables and empowers second guessing of physician decision making, and consequently the perpetuation of barriers in accessing care. This is a story about a law called ERISA, the Employee Retirement Income Security Act. Employee Retirement Income Security Act doesn't sound like a health law, and it really wasn't established as a health law. In fact, it was written primarily as a pension law in response to the Studebaker Corporation's plant closure, resulting in basically this company trying to screw a bunch of workers out of their pensions, shining a light on pension fraud, abuse, mismanagement, and needing to better protect workers. But as we see the rise of employer-sponsored insurance, which we'll talk about, what we end up seeing is that this law, which applies to both employee pension benefits and employee welfare benefits, is that this ends up becoming embedded in the story of American health insurance. And so one law professor wrote, think back on any number of stories of of health insurance atrocities. The Texas man whose employer was allowed to slash his AIDS coverage as he was dying of the disease. The retiree whose lifetime insurance was suddenly canceled. The woman who's with advanced breast cancer unfairly denied coverage for the only treatment that might save her life. All these cases had one unexpected thing in common: the monumentally boring, complex, far-reaching law called ERISA. And so one of the things that is just really striking is that this is really a story of this politics of unintended consequences that has shaped health insurance since its inception in 1974. So I wanted to first just sort of give a general sense of where the book is. So I've written about 110 pages of this thing. So basically where I'm starting is contextualizing this in the events of United Healthcare, and then thinking about how this law came to take on this role as a barrier to health security, and then looking at how this law also, for reasons I'm going to explain, upends health federalism. So over lunch today with some of the Masters in Public Policy students, we were talking about America's polarization. We're as polarized now as we were during Reconstruction, which was not exactly a happy-go-lucky time in the United States. And so one of the things that we will think about is, Louis Brandeis's famous words that states can act as a laboratory of democracy. But for reasons that I'll get into very soon, ERISA actually impedes all of that. And really prevents states like Virginia and Pennsylvania from taking action to expand health insurance access and equity. And so compiling all of the state laws affecting health insurance and identifying how their effects are really muted by this law, then looking at the legal repercussions and sort of how this structure of litigation incentives impedes access, then looking specifically in the context of AIDS, then looking at a nationwide survey that I'm actually going to present today for the first time, so you get the first peek. And then looking at the congressional attention to this law over time, then doing historical process tracing over a number of periods of proposed and enacted health reform, namely 1993, 1994 health reform, the attempts at the Patient's Bill of Rights in the later 1990s, Mental Health Parity and Addiction Equity Act of 2008, and the Affordable Care Act, and then looking within prescription drug policy, and then looking at the future of health reform. Hopefully there will be a future of health reform. We don't really know what's happening from day to day these days. So to give you a sense of today, I'm going to give you some brief context for the role of employer-sponsored insurance. The American way is really to tie health insurance to work, for better and worse, and then looking specifically at ERISA's role in health insurance delivery. Give you some context for my forthcoming book, Coverage Denied, which will be out in April, available for pre-order. Thinking about the role of federalism, drawing from ERISA preemption and the litigation incentives, and then I'll present some nationwide survey data, and then think more broadly about essentially if we have all of these health insurance access problems, and we've known about them for some time, why are we still here, and what do we do about it? But one of the things that I was mentioning earlier today was that a lot of scholars of health insurance understand that ERISA is a really big problem at the sort of 10,000-foot level. But we don't really understand its intricacies. So here, we have ERISA on the couch with a therapist. No one understands me. Well, you're right, ERISA, you're right. And it often takes a 150-page law review article, explication, or at the political science or sort of adjacent literature, it's just some broad hand-waving before moving on to talk about areas such as Medicare or Medicaid or the ACA, also very, very important areas of health insurance. But with employer-sponsored insurance being the dominant model in the United States, it seems very important for us to understand this better. So why do we rely on employer-sponsored insurance? Well, it actually really came about with World War II. So with World War II, we have massive restrictions on wages and prices, and basically in order to try to entice workers, employers couldn't increase salaries, they couldn't increase wages. So what they did was they increased fringe benefits, health insurance benefits. And so this was continuing to rise in popularity between the 1950s and the 1970s. ERISA is enacted in 1974. They'd actually been working on it since like the late 60s and then into the early 70s. And those of you who have studied American politics may be familiar that in 1973, 1974, things were a little complicated in American politics, and things were grinding to a halt with ERISA's legislative journey as attention turned to the Watergate scandal. And then Nixon resigns in order to avoid impeachment. Gerald Ford ascends to the presidency. Jacob Javits had been considered the grandfather of ERISA. And Ford basically goes to Javits and says, what's some legislation that I can sign and have a big show about that's pretty much ready to go? And Javits was like, ERISA, I've got your back. And so it gets signed into law over Labor Day. Now, employer-sponsored insurance has its perks, as some people in this room can attest to. We often have very good benefits. And basically, the way it works is we have a little piece of money taken out of our paychecks, something like $100, out of a $700 or so premium. It's a pretty good deal. The challenge is that it can produce job lock, meaning that you stay in a job you don't like because of the benefits. The Affordable Care Act helps with that, but it doesn't fix everything. And there's precarity amid economic downturn. So whether thinking about the Great Recession, in which I was very lucky to graduate from college during, or thinking about COVID-related job losses, when you lose your job, you can lose your health insurance. And so what we end up seeing is with ERISA, we are continuing in this journey of reliance on employer-sponsored insurance. Now, Ford may, for all we know, have been unaware that this applied to health insurance. It was signed into law over Labor Day. He talks about the labor implications, the pension implications. It actually only expanded to into employee welfare benefit plans sort of at the last minute. And that really is part of the problem, because they sort of added this category of things to which it applied, and they didn't fix the rest of the law. But it applies to something called self-insured health plans or self-funded health plans. And basically what this does, and this is something that larger employers do, so University of Pittsburgh, where I teach, William and Mary, I'm sure, basically they collect plan premiums from employees. They're responsible for paying medical claims, though they often work with a third-party administrator, such as an insurer like United Healthcare or Cigna. Now, this employee arrangement was not very common in 1974. 6% of plans were self-insured. So then in that case, it makes kind of a certain amount of sense that healthcare was not the dominant discussion in 1974. It was barely touching health insurance. Now 65% of covered workers are in these plans. And so there is this real politics of unintended consequences, this real reshaping of the policy context, and we haven't addressed the implications of it. Now, there are a couple of really core provisions of ERISA that really leave workers in these plans vulnerable in ways that we haven't had much discourse about, except in a brief moment in the late 1990s, which I know was well before many of you were born. One feature is something called preemption, where basically any state laws that touch employer-sponsored, this type of employer-sponsored insurance are preempted by ERISA. So anything that Pennsylvania wants to do to health insurance to promote access or equity can't touch the majority of employer-sponsored insurance. Anything Pennsylvania wants to do to improve insurance access and equity and affordability cannot touch the majority of employer-sponsored insurance. And again, this is a real problem in a time when federal action is difficult to come by. The other problem is that it prevents real legal recourse when patients are harmed by these plans, such as by being wrongly denied cancer treatment. And so essentially, when you are denied serious medical care and coverage, and in the United States, healthcare is notably expensive, so coverage is typically a necessary, if not sufficient, condition for healthcare. If you are denied and you're harmed, you can't sue for money damages, nothing for pain and suffering. All you can get is the treatment that may no longer be effective by the time a judge says that you're entitled to it. And you may not even get your legal fees back. And so this really makes it very hard for patients, especially patients from marginalized backgrounds, to be able to get their justice when they encounter health insurance barriers. So since I generally operate under the assumption that no one else other than me and maybe a couple other crazy people are kept up at night thinking about ERISA, how does this work? It's actually implemented through the Department of Labor, even though it is one of the most critical health insurance related laws that we have. It's through the Employee Benefit Security Administration, or EBSA, which is run by the Assistant Secretary of Labor. And so basically they do everything from crafting advisory opinions, information letters, they promulgate rules, they investigate potential violations. One challenge, as is often the case in administrative agencies, they don't have unlimited resources, and there are a lot of potential violations, so there's a lot of under-enforcement. And so this book really lies at this intersection of health and labor politics. So typically, again, when we have talked about ERISA, it's usually in the labor context, it's usually labor policy. And it's usually from the 10,000-foot view, or just sort of saying, well, we can have all these policies, but it's not going to apply to self-insured health plans. Now let's talk about something that's a little bit less complicated, which is almost anything. And so one of the questions that I've sometimes gotten when I've talked a little more obliquely about this project is, why are we stuck here? And I think the answer is that it's really opaque, and it's hard to fix something when we don't understand it. And so something that I'm hoping that this book is going to do is demystify some of this. So I'm apologizing. I'm about to provide a bit of a squeamishness-inducing example, especially for the men in the room. But one example of what can happen due to the challenges with ERISA's denial of remedies is illustrated in the story of a patient named Frank Wurzbacher, whose story was brought to light during a Senate testimony in 1998. So he was in a self-insured retiree health plan through his former employer. He was self-insured, therefore governed by ERISA. And he was a prostate cancer patient, and he was prescribed injections to try to prevent the prostate cancer from returning. And then his plan changed hands, changed to a different insurer. They decided that they would not cover the injections anymore. He was going to be on the hook for them. What they would cover in full, however, was castration surgery, very, very radical, and he did not have financial means, so he got the surgery. Then, about a week later, he's opening his mail. The insurance company says, oops, we screwed up. We should have covered this. And because ERISA denies legal recourse, all he was entitled to was the injections he no longer required. Couldn't get money damages for pain and suffering. He couldn't be guaranteed a recovery of attorney's fees, which can be expensive. Lawyers like to charge money. And so this hopefully really lays bare the precarity that American workers are in. And so obviously a lot of stories are not as devastating as this, but one other really heart-wrenching story was that of Natalie and Sarkeesian, a 17-year-old leukemia patient who was denied coverage for a liver transplant. And basically this ignited this firestorm of protests from nurses and doctors and patients in Southern California. And the Cigna eventually reverses its decision, but because of the amount of time that was taken, she actually died before she received the transplant. And because of the nature of ERISA, her family could not receive any money because the only thing that they could get was the transplant, and because she could no longer receive it because she wasn't alive, the entire family got nothing. This was actually a story that was so infuriating to then Cigna Vice President Wendell Potter that he actually resigned from Cigna and became a whistleblower. And so this really comes out of my forthcoming book, which covers pictured here, which examines the extent to which Americans experience health insurance barriers when trying to access care. And so I combined survey data, administrative data, and 111 interviews with patients, physicians, former health insurance executives, including Wendell Potter, patient advocates, health insurance lawyers, and so on, to really understand and unpack the human American experience of delays and denials, and how this can exacerbate what policy scholars refer to as administrative burden, or the experience of policy as being onerous. So the example I always talk with my undergrads about with administrative burden is sort of the red tape of going to the DMV, everyone's favorite afternoon, right? Sort of in and out, easy breezy, not so much. A good example of Medicaid work is also Medicaid work requirements, which require a lot of paperwork burden. And so what did I find here? I found that 36% of my survey respondents had experienced at least one denial, and that typically it was more than one denial, and that this really upended their health and economic lives and deepened inequities because of administrative burdens of appealing and trying to resolve these issues and access care. Because when you get denied, there's an appeal process, but it takes a lot of work. You have to know the steps. You have to know you could even appeal in the first place. And a lot of people don't do it. And so then we have inequitable administrative burdens of appealing. Then this leads to delayed and foregone care, which can then lead to worse health outcomes. And some things that I find is that lower income patients tend not to appeal, Black and Hispanic Medicaid patients and sicker patients tend not to fare well in the appeal process. And so obviously, as you can tell by now, I gravitate toward very chipper research subjects, but one of the things that I was really struck by was that in response to patient frustrations and physician frustrations with administrative burdens of things like prior authorization, states have been enacting laws to try to mitigate this, but it's all muted by ERISA. It's going to affect marketplace plans. It's going to affect Medicaid plans. It can affect Medicare Advantage plans, but it's not going to affect the majority of employer-sponsored insurance because of ERISA preemption. And one of the things that if you're thinking, God, this law sounds complicated, you are not the only one by a mile. The GAO characterized ERISA's preemption language as some of the most complex and confusing language in the federal code. The Supreme Court of the United States called it a veritable Sargasso Sea of obfuscation. Jacob Javits really actually did intend to have this preemption language. This part was not an accident. The impact on employer-sponsored insurance, yes, that was unanticipated. They did not know that private insurance was going to explode in the ensuing decades, but they wanted to have uniformity in pension plans. They didn't want Virginia and Pennsylvania going rogue. But then basically business associations then worked to entrench ERISA preemption because they stood to benefit from states not being stronger on regulation. And the implication is that this really stands in the way of really any state efforts to reform health insurance access to relieve administrative burden. And so now we can think about this in the lens of what political scientists and policy scholars have characterized as policy feedback. So this goes back to E. Schatzsnyder, which is not always my favorite name to spell out, but he writes very famously in 1935 that a new policy creates new politics. And so really when we introduce a new policy, it can reshape coalitions and create new conditions that people then have an incentive to fight for. So a classic example, Medicare. American Medical Association decried it as socialized medicine. They didn't want a Medicare to pass in 1965. It did. All of a sudden, seniors have access to health care. The AARP has an interest in representing this, and Medicare becomes pretty quickly entrenched, at least for now. And so what we end up seeing in the ERISA context is that we have this reshaping of coalitional alignments of business interests and health. And so then what we end up seeing is this fostering of a protective constituency that makes it harder for us to move from the status quo. And so what we end up is something that political scientists and policy scholars would refer to as path dependence, which essentially means that sort of once we're on a policy course, it becomes harder for us to veer off in other ways. And we also see that courts have interpreted ERISA preemption as being very broad. And so states have been precluded from taking a number of actions, including directly taxing employer-sponsored plans, regulating most employer-sponsored plan benefits, employing prior authorization reforms. And so again, this applies to self-insured plans, which were an infrequent arrangement in the 70s and have since taken off. And this is really consequential because coverage denials are not only prevalent, but increasing. So not only did I find that 36% of American adults experience at least one coverage denial, typically more than that, but Health and Human Services, Office of the Inspector General, found that 13% of Medicare Advantage prior authorization denials were wrongful. And Change Healthcare, which is a United Health Group affiliate, has found that the claim denial rate has gone up from 9% to 12% in a very short time span, just from 2016 to 2022. And a lot of those denials are front end, meaning prior authorization. Now, Congress has paid attention to this problem, to ERISA. They're not unaware of ERISA. They haven't addressed its defects, but that doesn't mean that they don't understand that it has taken on a new meaning in healthcare. And in fact, a number of key, really transformative health laws have amended ERISA. but none of them have addressed the denial of remedies. So we see, for example, that HIPAA, the Health Insurance Portability and Accountability Act of 1996, applied to group employee health plans. The Newborns and Mothers Health Protection Act of 96 applied to protecting mothers and newborns, hospital stays and coverage for that. The Mental Health Parity Act of 1996 addressed lifetime and annual limits for mental health coverage. Mental Health Parity and Addiction Equity Act of 2008 addressed mental health parity in these plans, and so on and so forth. The Affordable Care Act is kind of a funky one. So the congressional folks didn't want to touch ERISA, and for reasons I'll get into. And the Assistant Secretary of Labor at the time, Phyllis Borsey, who I had the pleasure of interviewing for this project, was pushing for ERISA reform, and they basically said, "Ugh, fine, you can look at the text for 3 hours or something like that." And so they're scattered throughout. Just a few small amendments, but nothing systemic. And the No Surprises Act, which prevents surprise medical bills, also apply to these plans. But again, we're extending other protections to employer-sponsored insurance, including those governed by ERISA. We're not getting at the big issues. And so we've seen, for example, 28 states having the regulation of the qualification of physicians reviewing prior authorization and ensuring that they're in the appropriate specialty. You may be surprised to know that if you are going to get medical care and there's a prior authorization, it may be reviewed by a physician in a different specialty. So for my forthcoming book, I interviewed someone, for example, whose rare neurological case was reviewed by a family physician, someone whose hearing surgery was denied by a gynecologist. These are pretty different parts of the body, last I checked. And we've seen Congress try to review, improve the timeliness of prior authorization review in Medicare Advantage plans. It died in the Senate, where bills typically die. We've seen Arkansas enact limitations on the application of prior authorization to antiretroviral drugs. And we've seen efforts to address AI. And all of these proposals could reduce inappropriate delays and denials. And this is really consequential for equity, because once people are denied, then they have administrative burden, which is unevenly distributed. And some other examples that I've been going through with a team of research assistants at the University of Pittsburgh, we can see requiring group health plans to cover medication-assisted treatment for substance use disorder, prescription eye drop coverage, stage 4 metastatic cancer coverage, contraception coverage. And ERISA is just fundamentally getting in the way at every step. So having explicated the joys of ERISA preemption, now let's talk about the remedies. So why is it that Frank Wurzbacher's story, squeamishness and awful though it is, how does this fit into this broader picture? So political scientist Sean Farhang at UC Berkeley, go Bears, put forward a litigation model where they can think about a rational litigant, a rational actor, sort of rational choice theory coming out of economics, where the expected value of a lawsuit is reflected as a product of the expected benefit of a lawsuit, so what you can get, so for example, monetary damages, times the probability with which you'll be successful, minus any costs associated with the suit. And basically the idea is if expected value is positive, you'll bring forward a lawsuit. And Congress knows this. And so in 1991, Congress amended the Civil Rights Act, the Civil Rights Act of 1991, to increase the value of civil rights lawsuits. And what we saw was this dramatic increase in people bringing forward suits. But ERISA has a very, very low expected value. All you can recover is the medical benefit. And so there are zero damages, so very low expected benefit. Litigation can be costly because you may not recover attorney's fees. In fact, if you have a bad case, you may have to cover United Healthcare sickness attorney's fees. And so this leads to a low expected value. And what I argue in this book is that there are two core implications that flow from this, one of which is insurer accountability. So lawyers are reluctant to take on cases that won't get them money. And patients are then going to lack legal representation, which means that there is a vanishingly low probability of an insurer getting sued if they deny expensive treatment. And so the implication is that insurers can essentially deny costly care with impunity. And so this would suggest that we can see not only a persistence of coverage denials, but a perpetuation of denials. And the second implication is equity. Lower and middle income, even upper middle income people are not going to roll the die and risk taking on these legal costs. And so if we leave this to chance, we could end up accruing not only medical debt, but legal debt. Now, the reason for this is simple. It's silly, but it's simple. And it's that Congress had set out to write a pension law. And if your employer tries to screw you out of your pension and you sue, you get your pension back. You're fixed. But when we're dealing with healthcare, we can get worse. We can deteriorate. And so basically, they added a new category to which the law applied, and they just didn't revisit the rest of the law, even though it functions differently. So then I asked the former Cigna VP, how aware is an insurance company of this? And he said there is a constant awareness of ERISA damages provisions. These companies know they're shielded by ERISA. They know that a patient who is denied coverage for a transplant or any other procedure is limited in terms of what their legal remedies are. They know this, and it affects their behavior. And they can become instantly aware if an enrollee is enrolled in a self-insured health plan or a fully insured health plan. And this really fits into a law and society literature, really led by this 1974, ironically the same year as ERISA, article called Why the Haves Come Out Ahead. It was written by Mark Galanter, and basically talks about how these repeat players like United Health, like health insurers or employers, are systematically advantaged over workers and patients. And this is really emblematic of that core thesis. So now, having really hopefully given you a sense of how sort of broken things are, now I want to get into a little bit of the survey that I conducted. So what I wanted to get at was essentially, how does this reshape litigation the incentives of patients who are or could be harmed by this law? How is this law working? How does an ordinary patient navigate this system? So I developed a survey in Qualtrics and then administered it through this platform called Sentiment, which provides census balanced samples. Surveyed 2,569 US adults in June of this year. Paid them $225, took them about 7 minutes to complete. Covered everything from demographics, employment status, health insurance status, willingness to bring a suit under ERISA's terms, insurance coverage denials, awareness of legal recourse, any legal action that they took. This is just comparing the sample to national figures. So I had a pretty good sample. Underrepresented Hispanics, which is pretty common in survey research. We tend to see somewhat lower response rates. Had a slightly lower than average share in employer-sponsored insurance, and a little bit lower income. But overall, it was a pretty good sample. So one of the things that I realized is most people don't know if they're in a self-insured health plan. Most people don't know the difference between an HMO and a PPO. So what I ended up doing was I asked them, what size employer are you in? So I estimated that a little over a quarter of my sample was in a self-insured health plan. But then I sort of took a step back and I decided, you know what, I want to ask these questions of everyone. And the reason why I'm conducting analysis on everyone, regardless of whether they're in Medicaid, ACA, employer-sponsored insurance, is that people often move between types of insurance. Perhaps you are working at a large firm and then you go, you know what, I'm going to start my own business. Then you might be on the marketplace. Then maybe there's economic downturn, you wind up on Medicaid. Then things get better and you wind up in a large employer. And so because there's sort of this shifting across insurance types, I wanted to capture sort of the constellation of patients who might encounter ERISA at some point. And so one of the questions that I asked was very simple. Has a physician ever told you that you needed a test or treatment for which your insurance company denied coverage? And a little over 30% said yes. That's a slightly lower share than I estimated in my forthcoming book, but different survey firm, different people, still in the same ballpark. And it's largely consistent with previous findings, which was that those in employer-sponsored insurance were more likely to have this barrier. And then I asked them about what they could recall about the reason why it was denied, and we can see that there was a broad distribution. So anything from a billing error by the physician or medical practice, coverage having been lapsed, investigational or experimental, lacking a prior authorization, a judgment of medical necessity for other reasons, and then sort of an other category. And so then, thinking about this in the lens of administrative burden, for those who are interested in this line of work, there's an outstanding book by Pam Hurd and Don Moynihan called Administrative Burden Policymaking by Other Means by Russell Sage Foundation Press. Look at me, I'm just doing a little promotion for my friends. And what they conceptualize administrative burden as is being comprised of learning costs, compliance costs, and psychological costs. So learning costs is figuring out what is this program, how does it work, am I eligible? Compliance costs is sort of the nuts and bolts of filling out forms, calling people. And the psychological cost is really what it sounds like. It's the stress, the anxiety, the overwhelm. And so this is typically applied to public programs, but what I have argued, as well as some of my co-authors, is that we can extend this to the private insurance framework as well, just given the reality of private insurance complexity and fragmentation causing a lot of informational burden. So most people don't appeal denials, even though we have a good chance of winning if we do. And the administrative burden framework helps explain why. So I asked them, did you appeal your denial? And so the horizontal dashed line, which hopefully you can see in the back, indicates the sample-wide average. So this was the share of people who won. So this was the percent winning their appeal. But what we can see here, Black and Hispanic patients less likely to win, college graduates more likely to win. People women are less likely, people who are less educated, lower income. So this is just to say that this is just sort of an illustration of the inequitable features of these denials that I argue that ERISA's design contributes to the perpetuation of. And so now let's think about the deterrent, the ERISA design as a deterrent effect. So there's a movie from the late 90s, The Rainmaker, so, it's a movie adaptation that shows this big jury award at the end. They bring down an insurance company. That just doesn't happen a lot of times in real life. Frank Wurzbacher could only get the injections he didn't need. Sarkisian's family never got anything. So then everyone who experienced a denial was asked whether they considered suing and whether they ultimately did so. A lot actually thought about taking legal action. Some did, a lot of them didn't. Now, there are different case-specific facts, challenges navigating the legal system, but there's also the challenge of finding a lawyer if you're not going to get money at the end of the day. And what I also found was that people who were estimated to be in self-insured plans were less likely to have secured legal representation. So I also asked them, if you considered legal action, what kind of relief would you want? So I didn't tell them what ERISA guarantees. I asked them, what would you want out of a lawsuit? Because what I wanted to get out was, is this law working for patients? Only 6% would have been content with just benefit recovery. Just 6% only wanted the medical benefit. Most people wanted some combination of the benefit, potentially lost wages from being sick and untreated, medical bills being covered, and then a lot of them wanted punitive damages. And so hopefully this highlights that ERISA's lack of remedies is fundamentally misaligned with the needs of patients. So I also asked, what are the challenges that you experienced or perceived in this process? So everyone who was considering legal action, regardless of whether they ultimately took it, was asked whether sort of what they perceived as challenges they would face in bringing forward a lawsuit. They could answer as many as they wanted to. Cost was the big challenge, of course. Well, bringing forward a lawsuit is expensive, but we also see illustrations of the learning costs. A lot of them didn't understand the the legal process. There were a lot of compliance costs, finding a lawyer, paying for legal advice, time spent on a lawsuit, and a lot of psychological cost, overwhelming. People didn't really know how to do this, and they had this intense navigation anxiety that I would imagine a lot of us can understand. So then I wanted to zoom out and ask everyone, basically, what are the conditions under which you would bring a lawsuit? Hypothetically, whether you've been denied, whether you've never been denied. So everyone, all 2569 respondents were asked whether they would be willing to bring a lawsuit for a coverage denial if they could recover the medical benefit but not damages, and if they would not be guaranteed to recover attorney's fees. Now, surprisingly, a little over half of them were still willing to do this, which is like a little weird. I wouldn't, but I'm not everyone. But then this is only, the aggregate picture is only part of what's going on. Now let's get under the hood and figure out what's going on with the equity picture. So put forward a few core hypotheses that probably are pretty straightforward, expecting lower income patients to be less willing to sue under ERISA's constraints. They're not going to have the flexibility to throw money away like this. So California Chief Justice Ronald George said, if the motto "and justice for all" becomes "and justice for those who can afford it," we threaten the very underpinnings of the social contract. I also argued that people who are less educated will be less likely to do this. So in addition to education and economics overlapping, there's also more learning costs, and so it'll be harder for them to sort of learn this process. I expected that people who are at fair or poor mental health will face worse psychological costs and therefore sort out of doing this. And the people who are generally more litigious, and therefore, by which I mean they've already brought lawsuits in the past, may just generally be less risk averse in bringing forward lawsuits. And so at the bivariate level, find that those who earn less than $50,000 annually were 13 to 11 percentage points less likely to bring lawsuits under ERISA's constraints, found a 9 to 13 point gap on education and a 10-point gap on mental health. So this is reporting the black bar is the willing to bring a lawsuit just for the medical benefit. The red bars are for without guaranteed attorney's fees. And so and the T statistics, they're from T tests. And so what we can see is that these are all significant findings with pronounced economic, educational, and health disparities. So then, zooming out to the multivariate context, and I won't get into the weeds here, the dependent variables, or the outcome variables, I looked at two dichotomous variables, yes or no, would you sue for the medical benefit only, and two, would you sue if attorney's fees are uncertain, because it's a dichotomous outcome. Using logit analysis, I'm just going to present the coefficients in a coefficient plot. Done a bunch of robustness checks that I'm happy to discuss. And this is obviously helpful because then I can sort of control for multiple things at once, including race, income, education, health status, litigation status, multiple chronic conditions, sex, age, whether you're rural. And so the race effect actually disappears when shifting from the bivariate to the multivariate analysis. But so the vertical dashed line is at the 0 mark. So if the error bars cross the vertical dashed line, it's not significant. But what we can see is that people who have lower incomes and are less educated and have worse mental health are all significantly, both substantively and statistically, less likely to bring lawsuits under ERISA's conditions. And that people who are more litigious are still going to withstand the scheme. And so this really suggests that there is a significant equity picture. Now, so what ends up happening with those 179 people who ultimately brought lawsuits? Big distribution. Generally speaking, things end up in settlement rather than court. Only a few people lost, and only 14% were unable to recover those costs of litigation. But that still suggests that, this is a non-trivial fact of life, and many people expressed in open-ended questions the significant psychological costs. So I asked people an open-ended question, in a few words, can you describe the emotional experience of pursuing the legal system to access prescribed care? People said they felt belittled by the healthcare system. I wanted to kill myself, that's how stressful it was. It was super devastating to my mental health. Anyone involved in legal proceedings will warn you a long, drawn-out legal battle will drain your mental health. Cried myself to sleep, felt taxing, powerless. Insurance companies call the shots. And so we can see, and this is a word cloud from other responses, but stressful and emotional pop up very plainly here. And so what do we make of this? So there really is not a whole lot of political science scholarship on this. And so what we see is that in 1974, the year ERISA was enacted, Mark Galanter talks about the haves coming out ahead in the legal system, and ERISA kind of shows that that's true. There is a lot of legal scholarship, but it's not sort of accessible to the masses. They're often very lengthy normative articles that tend not to get under the hood at the empirical implications. But this rational litigant model does show that there really isn't a lot of incentive to bring forward lawsuits. And that undercuts insurer accountability in a system where insurers are looking at both cost containment and profit maximization. And so what this can fuel is administrative burdens and inequities. And so what this survey research hopes to show is that ERISA not only is frustrating for a lot of patients, but actually operates as a structural driver of health and economic inequity, because less affluent, less educated, and less healthy patients will be willing to bring forward suits. So what are some things that are entrenching this? So one of my two favorite musicians is Bob Dylan, and my favorite Dylan song says, "Money doesn't talk, it swears." Obscenity, who really cares? It's All Right, Mom, Only Bleeding. It's on Bringing It All Back Home in 1965. Go listen to it. Your parents will like it. And one of the reasons is that as we saw private insurance becoming increasingly entrenched, we also see a lot more lobbying by insurance companies who have an incentive to entrench this law. And so this is lobbying data identified through the Center for Responsive Politics just from 2024. And there is a lot of it, looking at CVS, Centene, Cigna, Humana, Kaiser, United Healthcare, who have a vested interest in preserving the status quo. So as you've probably now gathered by this second meme, I'm a Mean Girls fan, the OG version. And ERISA's significance as this vehicle for health insurance barriers went undiscussed in the 70s and 80s. In the 90s, we see this onset of managed care, this managed care backlash that then brings health insurance challenges to the front of national discourse. But 1993, 1994, we see this notoriously failed health reform effort. And then sort of in the later 1990s, we see the Patients' Bill of Rights efforts. This actually sort of falls apart because even though we're now seeing increasing shares of people in these self-insured health plans, and Ted Kennedy is talking, and Frank Pallone are talking about people being abused by their managed care organizations. Ted Kennedy is talking about how it's a license to maim and kill. But politics. We end up seeing that the Patients' Bill of Rights dies in the Senate amid concerns about frivolous lawsuits, rising premiums that the Congressional Budget Office said would not happen, and ultimately the final nail in the coffin was the Clinton impeachment. And the 2009 to 2010 was ultimately an act of avoidance of past mistakes, trying to enact the ACA in ways that would avoid the sort of PTSD of the 90s. And really, even though it got 60 votes in the Senate, if it had gotten to 59, and it almost did because Ted Kennedy died, and the Senate seat was replaced with a Republican, there were so many moments when the ACA almost didn't happen. And to quote David Bowen, who was Ted Kennedy's right-hand man, when I interviewed him, he said it was within a blade of grass at the edge of a cliff, and ERISA would have been too much. And so hopefully, and I know I've gone on way too long, the irony is that this law really was actually meant to help American workers. It helped looking to protect their pensions. But we have this lack of foresight about what's going to happen to managed care. And so then we see these interests become really entrenched once they realize what they have to gain. And so then we sort of have this insufficient legal system. And so a lot of laws have amended ERISA, but none have really confronted these real realities that have contributed to a lot of the problems that people laid bare in the wake of the United Healthcare shooting. Even though ERISA undercuts health insurance equity, undercuts health insurer accountability, and prevents states from taking action when the federal government won't. And so reforming ERISA now is actually more critical, but the political conditions are more fraught. In my forthcoming book, I argue for shifting from prior auth to an audit-based system, but that's not going to happen anytime soon. So my students know that when I'm giving health policy updates about current goings-on, I want to give people a ray of hope. It's very hard to come by these days, so what I end up doing is just giving a picture of one of my cats. But I really appreciate your attention and would love to now have some conversation.
Yeah, we have plenty of time for questions, and if you have anything to ask, please just raise your hand so I can bring the microphone to you.
Thank you so much. That was a really informative talk, and I'm not sure if I need that, but I'll try to avoid feedback.
Can you talk to the recording? Is that possible?
Oh, sure.
Here. Sorry.
Thanks. So I just wanted to talk about your data, which is really cool. I wouldn't have thought to do a survey to try to tease out, what it is that is keeping people from suing and how much ERISA matters, but it's a really clever approach.
Thank you.
And I like that. But one thing I was wondering about is with the data being self-reported, we might worry that we're getting people's intentions about what they would do, and we're not getting their actual behavior. So that led me to think, are there any cases from the past where states have changed the legal recourse options in other segments of the insurance market?
Oh, that's a good point.
Like in the non-group market or in the fully insured market. So if economists in the room all know, we think in terms of natural experiments, right? So if there's something in the form of a policy change that changes legal recourse in another setting, maybe looking at how people respond in terms of filings and, like the actual lawsuits that we see, does that change relative to other states? So that's a great suggestion.
I just wrote that down. I'm definitely going to do that. Yeah, I mean, we know sort of anecdotal. We know more in the civil rights context than we do in the healthcare context. So the Civil Rights Act of 1964 mobilizes private litigants to bring lawsuits over employment discrimination. Ironically, was a compromise to actually stymie civil rights progress because they just didn't want to have a big civil rights administrative apparatus, but it turns out to be very potent. So we see the impact and sort of increased lawsuits when Congress provides new litigation incentives in the civil rights context, but I haven't looked at state changes to recourse in the healthcare context. So maybe I'll try to sort of actually maybe broadly across insurance settings. So that's a great idea. Thank you. Yeah.
Other questions? Great. I'll ask one while everyone thinks of their next question. Going back to the opening about states as laboratories of democracy, what are some of the most kind of creative or experimental ways that states are trying to deal with some of these sort of restrictions and barriers, or that you think that they could if they haven't already? Like, do you have any really sort of experimental laboratory kind of ideas for how to deal with ERISA?
Yeah. Some ways that states have, I wouldn't say, so it's not really ERISA, but some ways that states have tried to expand access within the context of insurance denials. California recently enacted legislation to ensure that there is better oversight of AI in their review of healthcare. So when you appeal a denial, generally speaking, your odds are about a coin flip, win about half the time. It's a lot better than most people think. Most people in my previous survey were just like, oh my God, I'm just one person. How could I possibly go up against UHC or Cigna or Aetna? And we often win. But in the context of AI denials, what we're actually seeing is that the reversal rate, meaning the rate at which people win these appeals, is like 90%. It means that something's going wrong. And so what some states, California so far and Pennsylvania is working on it, and I'm working with that legislator a little bit, is working to ensure that if there's going to be a denial, a physician actually has to look at it, and there has to be a person in the right specialty. And so the idea here is that we can at least reduce the number of inappropriate denials that are then going to sort of unleash all of this administrative burden and inequity. What I ultimately argue in my book and sort of my hand waving of policy recommendations and what's coming out, policy recommendations that are not going to come to fruition anytime soon, is I argue that we could do an audit-based model. So instead of imposing all of these front-end barriers to care, getting in the way between you and your costly medication or surgery or whatever, or scan, what we can do is audit the over-prescribers, audit the outliers, and maybe do random audits of everyone else. And then really maybe use prior auth as a penalty for the overprescribers. And the reason is that the reason why, I maybe I should have contextualized this for the non-health policy people in the room, is the reason why we have prior authorization is because we do have some prescription of low-value care. The problem is that the prior authorization is going after both low-value care and high-value care. And so if we can have a more targeted intervention and reserve prior auth for as more of a penalty, then that can promote access to care. And ironically, prior auth reform has actually been very bipartisan at the state level. When we look at the vote breakdown on the California law, and granted California is a Democratic state, but it's not a unanimous legislature, and it passed unanimously, or maybe had one no vote. So there is opportunity at the state level, but there aren't really easy ways to circumvent ERISA other than maybe finding ways for states to disincentivize employers from self-insuring. I think that would probably be the way to go, but I think that would get into, like, I don't know, tax incentives or some sort of economic policy that I'm not as well suited to figure out.
Thank you very much, Professor, for coming down here.
Oh, thank you.
I'm glad you mentioned prior authorization and your policy recommendation there. And I was wondering if you worry that getting rid of prior authorization might lead to an overconsumption of healthcare and driving up costs. So I was wondering what your response was to that.
Yeah.
And if this has been tried in California, if you could talk about how that has played out in that state as well.
Yeah. So I think that the idea, and like so no state has shifted to an audit-based model. This is just sort of me in my room coming up with, like, wave a magic wand. I think the guardrail, it would be that people don't like to be audited, and so theoretically that could dampen overprescribing, but that is a problem. So United States spends 1 out of every $6 on healthcare, soon to be 1 out of every 5, and it's not all high value. And and also this isn't just an economic issue. Some tests and treatments can pose a harm to the patient, and it could be radioactive exposure. It could be a medication with severe side effects that is unnecessary, and so it is a delicate dance. And so maybe audits aren't the way to go. I'm not sure. It's just sort of what I've conceptualized. In terms of the California law of regulating AI and ensuring that AI programs are not sort of going willy-nilly, denying coverage, it only went into effect in January. And so I think that the jury is still out on how well that type of reform is working. One thing that we are seeing is that some states are starting to think more carefully about this, but the federal government's going in the other direction. So Medicare doesn't usually do much in the way of prior auth, and that is changing effective January 1, where they're adding new prior auth administration, and it's going to be overseen by AI. What could possibly go wrong? And so I think that'll be, but we do know that Medicare does cover some unnecessary care. So maybe the audit penalty could mitigate overprescribing, but it definitely is a concern. Yeah, it's a good question. I see one hand over there.
You answered this a little bit with your discussion about the California law, but I was wondering, at the federal level, does potential ERISA reform break cleanly along party lines? Because it seems like it could cross-cut a little bit.
Yeah, that's a good question. So try not to just have my cynical hat on. So on the one hand, at the state level, we're seeing bipartisan support, and not just in California. In Pennsylvania, and I was talking with the state Congress, the state representative who wrote the legislation. He's a physician and it's funny, we were talking and he was just like, I don't support single payer, but the more I look at prior auth, the more closer I get to it. And I was like, keep going there, keep going. But it's co-sponsored by Republicans. So that shows that at the state level, there is opportunity. The challenge is that at the federal level, we are extremely polarized, and we have not only sort of partisanship, but a whole lot of negative partisanship. And I was joking over lunch earlier that my best characterization of that is in sports analogies, and I like it when the Yankees win. I love it when the Red Sox lose. And that kind of calcification of hyper-partisanship does take us from this could be a reasonable type of reform to not going to happen. So let's think about what has changed since the 90s. So on the one hand, the policy problem is bigger than the 90s, and there was some bipartisan support for this. So there was a representative in Georgia named Charlie Norwood who was a big fan of the Patient's Bill of Rights. But the challenge is that people don't really want to work together. Now, on the one hand, patients are more sort of vocally frustrated with insurance companies, and if political scientist David Mayhew is correct that members of Congress are single-minded seekers of re-election, then maybe there's going to be something there. Then we have to think about interest groups. So American Medical Association has had declining power. It used to be that something like 75% of physicians were in the AMA. Now it's down to like 15. And so if we sort of think about sort of what are the interest groups that are going to be the heavy hitters that can maybe lead us to not feel quite as hopeful, but this moment in December of 24 was cross-cutting. If you look at Ben Shapiro's Twitter mentions that week, people across the ideological spectrum, people who didn't like him on other issues, and people who did but thought he was wrong on this one, were fired up. And so I think the question comes down to, will Congress listen to the people? I think that there is ground level mobilization, sort of the bottom up processes. The question is sort of, will it happen? I wish I had a crystal ball. But the good thing is that prior auth reform there is an appetite across the ideological spectrum. And in fact, in 2022, Congress did pass, the House of Representatives passed unanimously some modest reforms to prior auth. Died in the Senate, but that does suggest that there is something, but yeah. Anytime you're mobilizing litigation, you sort of animate some people on the right end of the spectrum because there tends to be concerns about frivolous lawsuits and sort of concerns about rising premiums. The good thing, I think, that stands apart from health reform of the ACA or single payer nature is that this is a debate that is not about expanding benefits. It's not about expanding covered people. It's just getting the eligible person the benefit to which they're entitled. And that can take some of the politics out of it, but not all of it. That was a long-winded answer.
Any other final questions? All right, let's thank Professor Yaver for a wonderful talk.